Substance use disorder operates in plain sight. It moves through our workplaces, our daily commutes, and our communities, largely hidden by a lack of structural medical intervention. This map visualizes the crisis. Approximately 46 million adults are currently affected in the United States alone. Historically viewed as a behavioral issue, clinical science proves otherwise. It is a chronic, neurobiological medical condition involving impaired control, built-up tolerance, and physiological withdrawal. Using moral language to describe a biological illness suppresses patient care. This framing ensures patients remain hidden, which severs the trust required to initiate treatment. Adopting a neurobiological framework provides the structural basis for deploying the medical interventions that follow. The central operational problem we face is a disconnect between identifying a patient on the front line and getting them into specialized, evidence-based care. Fragmented referrals lose patients in the gap. Resolving this requires a continuous, integrated clinical pipeline. This pipeline operates in sequential stages: rapid initial screening, formal clinical diagnosis, and finally, multimodal medical intervention. Operating this system relies on specific professional nodes. Primary care physicians and EAP coordinators act as the intake filters, passing identified patients directly to specialized therapists and medical providers. While standalone support groups are common, statistical realities demand a highly structured, multi-stage medical architecture to achieve long-term recovery. Systemic intervention starts at the point of first contact. Primary care environments and corporate employee assistance programs serve as the entry points for the entire pipeline. Relying on subjective observation to spot at-risk patients fails. Providers must utilize rapid, validated screening tools. This diagram illustrates the screening mechanism. The Audit C is a validated, efficient tool designed to identify and isolate alcohol use risks out of a general patient flow. Lower in the funnel, the DAST-10 serves the same rapid filtering function, specifically identifying drug use risks. These screens are the first step of a protocol known as SBIRT: screening, brief intervention, and referral to treatment. Following a positive screen, the provider executes a brief intervention. This is a short dialogue conducted within the primary care setting to address risky behavior before it deepens. When brief intervention is insufficient, the protocol triggers a hard referral, routing the patient to specialized long-term treatment. Implementing this structured frontline filter converts primary care from passive observation into active clinical routing. Once routed out of primary care, the patient requires a formal clinical diagnosis to determine the exact nature of their condition. Automated online self-tests cannot fulfill this requirement. Definitive diagnosis strictly demands evaluation by a licensed clinician. This digital matrix represents the DSM-5 criteria. Clinicians use it to track markers like impaired control, high tolerance, withdrawal, and continued use despite consequences. The count of illuminated criteria dictates the severity of the disorder, grading it as mild, moderate, or severe. Patients landing on the severe end of the spectrum face deep physiological dependencies and significant disruption to their daily lives, requiring intense intervention. Because the severity is strictly quantifiable, it remains clinically treatable at every stage, provided it is correctly matched to the right interventional tools. A confirmed diagnosis triggers the intervention stage. Stabilizing a patient requires a dual-pillar strategy. The behavioral pillar utilizes cognitive behavioral therapy as the primary mechanism for rewiring the thought patterns that drive substance use. Paired with CBT, motivational interviewing focuses on overcoming patient ambivalence, generating the drive necessary for behavioral change. This architectural model illustrates the second pillar. Behavior alone cannot support the structure. The biological pillar is medication-assisted treatment, or MAT, stabilizing the underlying neurochemistry. For opioid and alcohol use disorders, specific MAT pharmacotherapies provide the foundation, including buprenorphine, methadone, naltrexone, and acamprosate. For decades, legacy referral networks relied on 12-step programs or smart recovery as their primary intervention. These mutual support groups provide value, but clinical data recategorizes them as adjuncts. They are insufficient as standalone clinical protocols. Attempting to resolve a complex neurobiological disorder with solely behavioral therapies or group meetings leads to failure. Dual-pillar integration is required for stability. Even a dual-pillar matrix will fail if it encounters undiagnosed psychiatric comorbidities. This Venn diagram reveals a critical reality. Approximately half of all people with a substance use disorder have a co-occurring mental health condition. Untreated mood and anxiety disorders actively sabotage SUD recovery. They degrade the patient's stability and serve as a catalyst for relapse. Conditions rooted in trauma, stress, or PTSD must be addressed in parallel with the addiction treatment, utilizing the same clinical resources. Treating an SUD in a clinical vacuum is systemic malpractice. Delivering integrated psychiatric care alongside addiction treatment is mandatory for durable stabilization. The pipeline faces one final point of failure: bottlenecks in geographic and financial access to these specialists. Overcoming these barriers requires a scalable, fully HIPAA-compliant telehealth network. This map of Georgia details the architecture used by Coping and Healing Counseling, or CHC. They execute this telehealth model across all 159 counties. CHC operates a structural protocol, coordinating their licensed therapists with external medical providers to ensure patients receive proper MAT management alongside behavioral therapy. They also utilize a financial architecture to eliminate cost friction. CHC is in-network with commercial carriers like Aetna, Cigna, and BCBS, accepting Medicaid at a zero copay. Without specialized low-friction delivery networks like CHC, clinical models remain inaccessible to the populations who need them most. This system's flowchart reveals the complete clinical pipeline, from initial frontline contact to stabilized recovery. It relies on primary care and EAP partners executing validated screening at the top of the funnel. It relies on licensed therapists and medical providers correctly executing the dual-pillar diagnosis and intervention downstream. Together, this pipeline creates an environment of continuous care, effectively treating patients at every point on the severity spectrum. Clinical and corporate partners must abandon legacy referral habits. Integrating these exact, evidence-based pathways into daily operations is the only way to secure patient outcomes. You can plug into this network immediately. Reach the licensed specialists at Coping and Healing Counseling by visiting chctherapy.com or calling 404-832-0102. Addressing an epidemic that affects 46 million people requires the disciplined statewide execution of this integrated medical pipeline.